Okay, sorry. Can you hear me?
Okay. Yes.
Okay, sorry. Thank you for the kind introduction. Today I'm going to talk about some of the new devices. One of them is the GeneValve that we have been using for the first two cases for pure aortic regurgitation. These are my conflicts. As we know, valvular heart disease increases with the aging population. The more elderly the patients, the higher chance that you will be having some sort of valvular heart diseases. So a lot of these actually are mixed valvular diseases. But if you look at the aortic valve in particular, especially when you look at the Chinese patients, actually aortic regurgitation is much more common than aortic stenosis. Even in the China DVD registry that was recently published, the aortic regurgitation at least is not too much less than the aortic stenosis. So you can see this diagram, AR basically might be actually more than aortic stenosis. And it's the same for aortic stenosis and aortic regurgitation. Once the patients having severe aortic regurgitation are asymptomatic, if they develop heart failure, class 3 and 4, then their prognosis would be much worse. So in general, their mortality rate at 10 years is about 34%. But if the patient is symptomatic, they will greatly increase the mortality. And if they are in class 3 and 4, this would increase to about one quarter of these patients will pass away in 1 year. Treatment-wise, still, if you look at the guidelines, the mainstay of treatment, if medical treatment fails, still surgical AVR is the class 1 indication. And if there are concomitant open heart surgery, then still surgical AVR is the treatment of choice. So TAVR is never in these guidelines for pure AR. Of course, there are a lot of inoperable patients, of very high-risk patients. So if we have to treat these pure AR patients, some of us will retreat to the TAVR devices that we are having nowadays. So if you look at the earlier generation and then the newer generation of the currently available TAVR devices, you can see that, yes, we can do this, but it comes with a lot of complications, especially second valve, residual aortic regurgitation, or actually a lot of these procedures actually are failed procedures. And then if we compare, there are two devices available for treatment of pure AR transcatheterly, both the J-valve and the JeneValve dedicated devices. If you compare this even with the newer generation TAVR devices, other than these two, you can see that the success rate with dedicated devices is actually much better than the even the newer devices for TAVR. The main problem with pure aortic regurgitation is, unlike aortic stenosis, which has a very, very calcified aortic valve, there is basically no calcium in patients with AR, pure AR, and then a lot of time there would be dilated aortic root and even the ascending aorta. This would actually make the anchoring very, very difficult. The valve tends to migrate or even displaced, and then sometimes may result in a lot more regurgitation than we wanted to. So these are the currently available TAVR devices being used in selected patients. Yes, we can do this, but as I mentioned, there is a higher chance of paravalvular leakage and a higher chance that we would need a second valve. So we have been treating pure AR patients, inoperable patients, back in 2015. This was our case. By then, at that time, we were still using the core valve. As you can see, severe aortic regurgitation. We use two pigtails to mark the annulus because we cannot see any calcium, as you can see here. Actually, end result was, I would say, quite satisfactory. If you can see here, not much aortic regurgitation, and the position actually was quite satisfactory. We are happy. We thought that we've been successfully treated this patient even without any calcium. But then 4 hours later in our CCU, we observed ventricular tachycardia and marked decrease in our diastolic blood pressure. And then actually the valve migrated down. In this particular case, we have to put in a second valve, snaring the first valve. Although the end result is quite satisfactory, but still the patient will need a second procedure right after the first one, and then end up with 2 valves. And then we have also been using the J valve, but this was at that time still a transapical procedure that we have to ask our surgeons to do it with us in our hybrid OR. This valve received CFDA Chinese approval in 2017. This was one of the cases that we have done in our hybrid OR. Residual aortic regurgitation actually was very, very minimal, but this procedure have to be done transapically. And then the Yen valve trilogy was the first approved TAVR device for AR. Actually, it's approved for AS and AR and received CE mark back in 2021. It has came all the way since 2009 with a lot of modifications, received CE marks for both AS and AR until the current generation of the TF2 system. It's basically a 19-0 frame again, but you can see that the coronary axis, the cell frame, the cell size is very, very large. So this is very favorable for future coronary access. And then there are 3 porcine pericardial leaflets inside the 19-0 frame. And what's special about this valve is these 3 locators, in which the locators can actually get grabs of the cups, the coronary cups, so that you can stabilize the valve and then allow the valve to deploy and then a function of the aortic valve. So basically, what we have to do is to align this valve. The locators have to be aligned with the 3 cups. And if, after deployment, if we can align all these, it will have actually very a good sealing and a very stable securement. And then, as I mentioned, the coronary axis, because of the big cell size, is actually very, very favorable. It comes with 3 sizes, covers basically most of the anatomy, I would say. So it is actually a stepwise deployment of the system. The first deployment is this deflector. You have to actually rotate this deflector and align the position of the catheter with the aortic annulus. And then this controller actually allows you to push forward the whole system. And then you would then try to align the cups by rotating the C-arm so that to make sure that the middle one is really in the front part of the system. If it is at the back, then you will have to rotate. And this rotation has a very, very good torque control. So once you rotate, the locators will rotate and then to the position that we would want to. The middle marker, the middle locator have to be in the front part of the whole system. And then actually you advance the controller to allow the locators to get grabs of the coronary cups. And then once we are sure but the height, then we will actually do a selected cups angiogram just to look at the position of the locators, whether they are in the right, left, and non-coronary cups. Once we are sure, we can actually release the whole system and the valve will be released and will have the function. Then we would continue to retrieve the whole system back to the sheath. You can see that actually this sheath goes all the way to the ascending aorta so that it will actually protect the 3 locators. It will not be caught anywhere along the ascending aorta. And then the whole system will be retrieved, and the device will have the function, and the position will be very, very stable. This was the first case. It's actually the first case in Asia. 79 years old gentleman. You can see that we don't see any calcium along the aortic annulus, so that if we use the currently available TAVR device, the risk of migration would be actually quite high. So quite a favorable angle for our procedure. And this was the procedure. You can see that the initial angiogram show a severe aortic regurgitation. And then we first of all align the 3 locators. And then once we are aligned, then we have to do separate cups angiogram to make sure the locators are really in the 3 cups. And then we can deploy, and the valve will function. You can see that residual aortic regurgitation is really, really minimal. This was the second case. Again, a smaller valve, smaller annulus, again, without any calcium that can be seen, so that the ordinary device would actually make it the procedure a lot more difficult. So we use this angina valve trilogy system to treat this patient. Again, you can see the marked aortic regurgitation on initial angiogram, and then the 3 locators advanced and then align, and then we have to check with separate cup angiogram to make sure that the 3 locators are in the correct cups, and then deploy the valve, and resulting in much reduced, I would say, not much residual aortic regurgitation at all. So both patients have been discharged the next day without any complications and no heart block. So there have been a registry data showing that this system have been used quite successfully. This was a German registry involving 95 patients. You can see that they are treating patients with both aortic stenosis and aortic regurgitation. These are the patient profiles with the Euro 2 score 5.8. They are using quite a number of smaller valves, and mainly pre-dilatation for the aortic stenosis. We don't really need pre-dilatation for aortic regurgitation. And if you look at their complications, it's actually very, very favorable results, even compared with the currently available TAVR devices that we have. And the resultant paravalvular regurgitation was only none or trivial, very, very few mild, and then no moderate or severe regurgitation at all. One point to note that for this inner valve to treat AR, sometimes you might encounter heart block, and we might need to implant pacemaker for these patients. I think this is something that we still have to address in the future, as compared to aortic stenosis, only 3% pacemaker rate. So to sum up, treatment of aortic regurgitation with TAVR is quite challenging, and if we are using the currently available devices, it would come up with poorer outcomes, I would say. For these patients who are eligible or at high risk for surgical AVR, in the past, we don't have any treatment options for them. And these results with the inner valve actually give confidence to us that the TAVR procedure for AR can save lives and reduce symptoms if we can achieve good results. This inner valve trilogy system is the only approved device for now for both aortic stenosis and aortic regurgitation. And the design of this system is actually good for the AR, for pure AR without calcium, because of the unique mechanism for positioning, securement, as well as the sealing. We have the honor to perform the first 2 cases in Asia in May, and actually confirm that this transfemoral system to treat pure aortic regurgitation is safe and effective. Of course, we need further studies to further prove the safety and efficacy with more patients in a larger cohort and expand the population. Thank you very much for your attention.
Thank you, Dr. Kang. So discussions will be done after all the lectures. Please go ahead to second lecture.
Okay. Let me see if I can share the second. Let me see. Okay, just this one. Okay. So you can see my slides. Okay. So my second lecture is on the, how we can actually optimize TAVR outcomes in.
Can you show the slideshow?
The
slideshow. The slide is looks very small, multiple.
No, it's not. Yeah. Let me see. I shared this already. Can you see?
We cannot see in slideshow.
Huh?
You're in slide sorter view. If you don't mind clicking the slideshow at the bottom.
Yeah, I click this. So still slide. Can you see it?
No, we see still the slide sorter view.
Okay. Let me see. How can I do this? No. Maybe I share again. Maybe.
Perfect. Working.
Okay. Can see now. Okay. Thank you. So my second talk is on the how to optimize TAVR outcomes in patients with small annuli. So this is a particular problem in our locality. We don't really have a common consensus on the cutoff values. What does it mean by small aortic annulus? But usually for our locality or in our center, we will take like annular area less than 400, perimeter less than 72, or the annular diameter less than 23. Or we need a prosthesis which is less than 20 mm in size. So it is more common in Asia and Southern Europe. And actually, if you look at the surgical cohort, this small valve are actually being used in almost 1/3 of their patients. And females are actually accounts for the majority of these small annulus patients. And once the surgical valve have been put in, which is a small one, then it will pose a special problem for our future TAVR procedures. So the main problem with small annulus, once we fix it, either with surgical AVR or a TAVR, is mainly because of this patient prosthesis mismatch. So once we measure the effective orifice area, if it is too small for that particular patient's body surface area to generate adequate cardiac output to meet the patient's demand, then we will call this patient prosthesis mismatch. And the cutoff values usually is like moderate ppm, usually is 0.65 to 0.85 cm square per meter square with the body surface area, and severe means less than 0.65. But once the patient is an obese patient, BMI more than 30, then we might need to do some adjustment as in here, which is actually a little different with different guidelines, different recommendations. So this small anatomy is very commonly seen in Asians, Japanese, Asian, Chinese. And the main problem with this small anatomy is that there is a higher chance of annular rupture if we use a little oversized balloon, especially in calcified annulus, coronary obstruction. A lot of times it would come with the small iliofemoral arteries, vascular complications, and AV conduction disturbance. But still, the main problem will be this patient prosthesis mismatch, which actually increase the mortality and morbidity of these both surgical AVR and TAVR patients. And actually, it would actually increase the structural valve deterioration of both the surgical valve and the TAVR device. So this is our typical patient, female patient. You can see that the annulus average is 19.4 with area 270, perimeter 60. So, and then the small Valsalva and the very borderline STJ. So this might be some of the typical patients that we see in Asia, in Japan, every now and then. If you look at this Japanese data, they compare their size with the European, you can see that they have a smaller aortic annulus, smaller SOV, and a lower coronary height, as well as lower STJ. So most likely, when they have to choose a TAVI device, they would choose a very small TAVI device. If it is balloon expandable, maybe 23, 20, or an absolute device would be 23, 26. So as I mentioned, for small coronary, for small aortic root, there would be higher chance of coronary obstruction, especially when it comes with the low-lying coronaries. And then if we use a little oversized balloon, then a chance of annular rupture will be higher, especially with very calcified and small aortic annulus. But if you look at the surgical cohort, after surgical AVR, if the patient developed patient prosthesis mismatch, then you can see that with severe PPM, the survival actually is lower. There would be more clinical admission because of heart failure, or there would be actually higher chance of redo AVR in the future. So all this comes with severe patient prosthesis mismatch. And if you look at this meta-analysis, you can see that severe PPM actually is a main risk factor for mortality after our TAVR procedure. So both surgical AVR and TAVI procedure, we would expect actually higher mortality if the patient develops patient prosthesis mismatch. If you look at the COVAR US pivotal high-risk trial, you can see that the highest risk for patients would be for patients with small annulus to develop severe PPM. And then the chance of this happening would be actually higher in the surgical cohort rather than the TAVI cohort, although the TAVI cohort also have a higher PPM in small annulus. And then all these, if it is in small annulus, all these will translate into a higher mortality in this sort of high-risk patients with severe PPM. TVT registry also shows that if patients develop severe PPM, then their chance of mortality or hospital heart failure rehospitalization would be a lot higher than those without severe PPM. And predictors of this severe PPM might include female patients, in particular, valve-in-valve procedure or very small valve size. So if you look at the TAVI small registry, this have been using the self-expanding valve. You can see again, patients with severe PPM, but not moderate PPM, will have a higher chance of mortality as compared to other patients. Ocean TAVI registry is a Japanese registry. They have a specifically look at the small and extreme small aortic annulus by using both the self-expanding and balloon expandable valve. You can see that for small aortic annulus less than 23, the chance of severe PPM is actually higher with the balloon expandable valve. And the same for extremely small, less than 21 mm cohort. Again, this balloon expandable valve actually will end up with much more severe patient prosthesis mismatch. This also translates into a worse hemodynamics for the balloon expandable valve, both in terms of the gradient as well as the aortic valve area. But if you look at the outcomes, the all-cause mortality, actually, this does not make much difference. So I would say, although balloon expandable valves nowadays will result in smaller effective orifice area and higher ppm, but we still don't know what this means, because in the long run, we don't see a higher mortality even with higher ppm or smaller effective orifice area. And this compare the balloon expandable valve and self-expanding valve in patients with small annuli. You can see that self-expanding valves will result in a higher chance of paravalvular regurgitation, but balloon expandable valve will result in a higher chance of both moderate and severe patient prosthesis mismatch. But again, this does not translate into long-term clinical outcomes, mortality, rehospitalization, also valve deterioration. Is more or less similar between the two cohorts. In the self-expanding valves, if we consider only this self-expanding valves, you can see that those with supraannular function actually would end up with a higher effective orifice area and less ppm. But again, we don't know what this means, how it translates into future clinical events. If we consider the patient as a whole, actually, if the patient is small built, then we are expecting smaller annulus. So for these sort of patients, even if they develop ppm, the clinical outcomes actually would not be actually as worse as those patients with big body build but small aortic annulus. So if you look at this, this is particularly important. They will have a higher chance of severe ppm if the patient is big size but with a small annulus. So we have to be careful with these sort of patients. And then from the Ocean TAVR registry, we can also see that severe ppm actually is associated with more leaflet thrombosis. These have to be investigated more in the future, whether severe ppm actually is associated with increased leaflet thrombosis, in which we have to step up our anticoagulation therapy after TAVR for these patients. So my take-home message is we have to be aware of small annulus during our TAVR procedure. These small annulus actually are more common in Asians, Japanese, Chinese, and then the small annulus in particular will give rise to a lot of problems, patient prosthesis mismatch, annular rupture, coronary obstruction, to name a few. And severe ppm is associated with increased mortality after TAVR and surgical AVR, I would say, increased readmission for heart failure, and also increased reduced SAVR or TAVR. And it might be associated with early leaflet thrombosis. We can achieve better hemodynamics with self-expanding valves, especially with the supraannular design, but there have been inconsistent data on the critical outcomes after a self-expanding valve, a balloon expanding valve for small aortic annulus. So my way to prevent ppm is, I tend to use more of the self-expanding valve if the annulus is really small. And then I tend to do a lot more post-dilatation just to maximize or optimize the valve for future benefit of these patients, especially when we move to younger, lower risk patients. Thank you.